A 27-year-old man presents with a colicky pain in left flank and urine dipstick test reveals hematuria. A plain radiograph reveals opacification in his bladder, which is thought to represent past calculus. What is this calculus most likely composed of? Now see, this patient had a left flank pain. That means the patient had left renal calculi, which has passed down into the bladder, and in the bladder, what is there? A calcification or opacification is seen in the bladder. Now, which is this calculus most likely composed of? Now, indirectly, the question is asking which is the most common type of renal calculus. It is what? It is calcium oxalate. So, correct answer will be calcium oxalate. So, some important points which are frequently asked in exam. Let us discuss them. So, we have most common type of kidney stones or renal stones. They are what? They are calcium oxalate. Clear? Now, bladder stones, we divide the bladder stones. We have primary bladder stones, secondary bladder stones, and migrant bladder stones. Now, so we have bladder stones. These are of three types. We have what? We have primary bladder stones. We have secondary bladder stones. Then we have migrant stones. Now, these primary bladder stones, they are formed in the absence of any anatomical, functional, or infective etiology. So, they are formed in the absence of any anatomical, functional, or infective etiology. Clear? Whereas secondary bladder stones, they are formed in the presence of anatomical, functional, or infective etiology. Most common type of primary bladder stones, we have ammonium urate stones. Ammonium urate stones, these are the most common type of primary bladder stones. And what are the risk factors? They are mostly present in children of age group 3 to 4 years of age. So age group is 3 to 4 years of age. And what are the risk factors? High carbohydrate diet, intake of polished rice, then exclusive breastfeeding in the childhood, then low phosphorus diet. These are all risk factors for primary bladder stones. So if we write it down, we have exclusive carbohydrate diet, which includes polished rice. Then we have exclusive breastfeeding. After that, low protein diet. Clear? Low phosphorus diet, because low phosphorus diet will lead to increased excretion of ammonium urate in the urine. Clear? After that, secondary bladder stones, I told you they are formed in the presence of anatomical, functional, or infective etiology. Now, these can be diverticular disease of the bladder. Clear? There can be neurogenic bladder. The risk factors include diverticular disease of the bladder, neurogenic bladder, presence of Foley's catheter for a long time. Foley's catheter for a long time, or there can be bladder infections. So all these are risk factors for secondary bladder stones. And which is the most common type of secondary bladder stones? It is uric acid stones. So most common type of secondary bladder stone, it is what? It is uric acid stone. Clear? Now, third variety, we have migrant stones. These are the stones which have passed from above to downwards, like from kidney or ureter into the bladder. And these are mostly what? Calcium oxalate stones. Because you know the most common type of renal stones, they are calcium oxalate stones. So in this case, the correct answer will be calcium oxalate stones, because they are the most common they are the most common type of kidney stones. A 22-year-old man suffers a severe pelvic fracture and has hematuria. You get a retrograde cystourethrogram and see extraperitoneal rupture of the bladder. The most appropriate therapy is. Now, please remember that in the treatment of extraperitoneal rupture of the bladder, it is what? You just have to insert the Foley's catheter and keep it there for some time, like 2 weeks, so that it allows the bladder wall to heal. Now, before coming on to the options, let us have a look on bladder rupture. We have two types. We have intraperitoneal and extraperitoneal rupture. Intraperitoneal rupture is trauma to the lower abdomen when bladder is distended. So always remember that when the bladder is distended, the chances of, and the patient suffers injury in a distended bladder, the chances of intraperitoneal rupture, they are more. Clear? and bladder dome is the weakest point and ruptures most commonly. Which is the most common site of bladder rupture? It is bladder dome. So the contrast extravasation, it can be seen in the paracolic gutters and between the loops of the bowel. Clear? As you can see in this, there is extravasation of the contrast in the abdominal cavity, in the peritoneal cavity. Whereas in extraperitoneal rupture, what happens? It is almost always associated with pelvic fractures, and it is usually close to the base of bladder in the anterolateral direction. And in this, there is no contrast extravasation. It is localized in the extraperitoneal space. Clear? Now, after that, if we see, now in this diagram, you can appreciate there is what? There is contrast extravasation. So this is the contrast is extravasating from here into the peritoneal cavity. So this is intraperitoneal rupture. Similarly, you can see in this figure, there is contrast extravasation from bladder into the peritoneal cavity. So it is intraperitoneal bladder rupture. Always remember the dictum is, if there is intraperitoneal rupture, you have to go for surgical intervention. You can go for lower midline laparotomy and do the surgical closure of the bladder. Whereas in extraperitoneal rupture, you just have to do catheter drainage. Now in this question, it is asking the patient has what? Extraperitoneal rupture, so you have to go for Foley's catheter drainage. Clear? Most reliable investigation to know the length of posterior urethral stricture is, now posterior urethral stricture, that is proximal urethral stricture. The most reliable investigation, it will be anterograde urethrogram. Now you see in this patient, you can see what? This is bladder. This is what? This is prostatic urethra. Clear? This is membranous urethra. This is bulbar urethra. And this is penile urethra. Clear? Now, if you have to assess what? The proximal urethra, we go for what? Anterograde urethrogram. Clear? And if you have to assess distal urethra, you have to go for retrograde urethrogram. Clear? Now in this case, you can see there is a stricture at this level. Clear? Now if there is a stricture at this level and we inject the dye from here, it can only go up to this. So it will be retrograde urethrogram. And in this, when to assess the proximal urethra, you have to inject the dye from here, that is termed as anterograde urethrogram. Clear? So assessment of primary, the proximal urethra or posterior urethra, is always done with anterograde urethrogram, and distal urethra, it is done with retrograde urethrogram. Now the best time for surgery of hypospadias is, it is important one-liner, the best time is ideally 6 to 12 months of age. Now if you see the options, the best possible option is option B. Clear? Now something about hypospadias, it is important topic, frequently asked in exam. We have the various types. We have the anterior type, which is granular or subcoronal, and please remember granular is most common type. So granular hypospadias, it is the most common type of hypospadias. Then we have middle hypospadias, which involves distal penile, midshaft, and proximal penile. Then we have posterior hypospadias, it involves penoscrotal, scrotal, and perineal. Clear? After that, the most common type I told you is anterior, and among it is granular. So it is present in 70 to 90% of the cases. Symptoms, cosmetic concerns may come later. It is single stage repair, and complication rate is very less, 1 to 10%. Middle type of hypospadias, it accounts for around 10% of the cases. Treatment and complications may vary between anterior and posterior. And posterior urethra again accounts for 10% of the cases. There is independent predictor of future complications. Workup for avoiding mechanics. It is a two-stage repair to avoid very high complication rate of single surgery. So the more proximal the hypospadias, the more is the complication rate. Please remember this dictum. The more proximal the hypospadias, the more complications, the more are the chances of complications. And proximal hyposphadia, they are treated by two-stage surgeries, two-stage surgical procedures. Retroperitoneal nodal disease in a young male is what? So the most common cause is germ cell tumor. Retroperitoneal nodal disease in a young male is germ cell tumor. Now, we have testicular tumors are of two types. We have germ cell tumors accounting for 95% and non-germ cell tumors for 5% of the cases. Now, germ cell tumors, it includes seminomas and non-seminomatous germ cell tumors. Seminomas, the classical seminoma accounts for 85%, spermatocytic seminoma 5% cases, and aplastic 10% of the seminomas. Then non-seminomatous germ cell tumors includes embryonal carcinoma, yolk sac tumor, teratoma, choriocarcinoma. Sex cord stromal tumors include Sertoli cell tumor, Leydig cell tumor. The other causes, they are metastasis and lymphoma. And I told you most common sites is the retroperitoneum. Other sites can be intracranial, mediastinal, pelvis, and gonadal, but the most common site is retroperitoneal. So the question is asking retroperitoneal nodal disease in young male is germ cell tumor. The correct answer is A. So next, a 50-year-old female patient presents a hard mobile lump of about 5 cm in her right breast. In her outer upper quadrant, underwent mammogram reveals a speculated heterogeneous lump. True-cut biopsy was done. It was found to be inconclusive. Clear? What will be your next step? So in this case, you see this patient has a carcinoma breast because the mammogram is showing what? Speculated margins. So speculated margins is characteristic of carcinoma breast. Now true cut biopsy was done, which was found to be inconclusive. Clear? Now inconclusive, if true cut biopsy is inconclusive, next step is what? It is excisional biopsy. Now please remember the first investigation to be done in case of lump breast, it is what? It is first investigation is FNAC. So first investigation to be done in breast lump, it is FNAC. The best investigation is it is true cut, core cut, or needle biopsy. Clear? But if this core cut biopsy it is inconclusive, the next step is what? If it is inconclusive, the next step is you go for excisional biopsy. Clear? There is no point in repeating the true cut biopsy, so we will not repeat the needle biopsy. We will not repeat the FNAC. No need of doing MRI. We will directly go for excision of that lump, and we will do excisional biopsy. Clear? A 45-year-old female presents with a hard lump in her breast. Which of the following will be the most helpful in diagnosis? So the question is asking most helpful diagnostic test. It is what? It is excisional biopsy. Now in excisional biopsy, what we do, suppose this is breast. Suppose this is a lump. So the lump is here. Clear? So this is a breast lump. In excisional biopsy, what we do, we will take out the whole of this lump is taken out, excised. So it is excisional biopsy. Whereas in incisional biopsy, what is done, a part of the tissue of this lump, it will be excised. So, but the best, most helpful, which will give us the maximum details, it will be excision of whole of the lump. Now you see FNAC, I told you it is the first investigation to be done. Core cut or true cut biopsy, it is again after FNAC, it is the investigation of choice or best investigation. Clear? Incisional biopsy is taking a tissue sample, taking a tissue from the margin of the whole lump. It is incisional biopsy, and excision is excision of the whole of the breast lump. So the most useful, the most helpful in diagnosis among all this will be excisional biopsy because it will help us in giving maximum details. Clear? A family of a patient of carcinoma breast who has underwent MRM comes to the chief of surgical team to know the condition of the patient and also about the survival prospects of the patient after treatment. Which of the following is the best parameter to guide to explain about the survival? So the best parameter to guide the survival, it is pathological staging of the carcinoma breast. So the correct answer will be pathological stage. Important one-liner, the best parameter to guide the survival of the patient in case of carcinoma breast, it is what? Pathological staging. So important one-liner. So some important points which are frequently asked in exam. Best prognostic index in case of metastatic carcinoma, it is what? It is hormone receptor status. So best prognostic parameter in metastatic carcinoma breast, it is what? It is hormone receptor status. Whereas best prognostic indicator in CA breast, it is what? It is best prognostic indicator in CA breast, not metastatic but CA breast. It is axillary lymph node status. Clear? If it is not given in the option, then tumor stage. If it is not given in the option, then we have tumor size. Clear? Now third, best prognostic parameter to explain about survival, it is what? It is pathological stage. Clear? Now, which of the following types of carcinoma breast has best prognosis? Now the options are luminal A, luminal B, HER2 amplified or basal-like. Before looking into the options, let us have a look on luminal criteria that are used. So we have what? We have luminal A, which includes ER/PR positive but HER2 negative, and they have low Ki67 levels. It is less than 14%. Then luminal B is what? It is of two types. It can be HER2 negative or HER2 positive. In HER2 negative, ER/PR is positive, whereas HER2 is negative. Whereas in HER2 positive, ER/PR along with HER2 is also positive. It is also called as triple positive breast cancer. Triple positive breast cancer. Clear? Then HER2 overexpression, it is HER2 positive and ER/PR negative. Clear? Whereas basal-like is triple negative breast cancer. Now always remember, most common type is luminal A. It is the most common type. So most common type is luminal A, and it has got best prognosis. Clear? Least common type is triple negative breast cancer, also called as basal type. It is the least common type of breast cancer. Then we have worst prognosis. Worst prognosis. Worst prognosis is seen in ER/PR negative, HER2 positive. So it has worst prognosis. Clear? After that, let us have a look on neoadjuvant chemotherapy. Indications are triple negative breast cancer of more than 1 centimeter size. Then HER2 positive breast cancer more than 3 centimeter or node positive. High risk luminal breast cancer and inflammatory breast cancer, that is T4D. Clear? Now what are the advantages? We have, it helps in evaluation of sensitivity, enabling breast cancer surgery, conservative surgery, downstaging of lymph node status. Then we have micrometastasis eradication and tailoring of adjuvant therapy. Now what are the disadvantages of neoadjuvant therapy? We have their adverse effects. There can be cardiotoxicity or neuropathy. It may delay the surgery. Healing difficulties after surgery are there, and progression can occur due to neoadjuvant chemotherapy. Now main goal of neoadjuvant chemotherapy is achieving pathological complete response. Clear? Now in this question, what is asked? Which of the following has best prognosis? I told you the best prognosis is luminal A. So the correct answer will be luminal A. Oh, coming on to the next question, number of genes evaluated in Oncotype DX test. Now how many genes are evaluated? The correct answer is 21. Now let us have a look on this Oncotype DX test. Now in this, it is basically a genomic test of the expression of 21 genes. It includes 21 genes, in which there are 16 tumor genes and 5 are housekeeping genes. It utilizes RT-PCR technology on FFPE tissue, that is formalin fixed paraffin embedded tissue. Clear? Quantitatively predicts the likelihood of breast cancer recurrence in women with newly diagnosed early stage invasive breast cancer. It assesses the likely benefit from both hormonal therapy and chemotherapy. It is the only multi-parameter gene expression assay to show clinical utility in breast cancer, and it is recommended by clinical practice guidelines. Clear? And if we see which patient they may benefit from Oncotype DX test, we have clinical indication is if the patient is newly diagnosed early stage invasive breast cancer. Clear? It can be node negative or with one or three positive nodes. It can be metastatic or locally advanced breast cancer with four positive lymph nodes. Clear? Now, it can be ER positive or HER2 negative. Now, in ER positive, HER2 negative Oncotype DX test, it is used. Clear? And in according to NICE guidelines, what they say in newly diagnosed early stage invasive breast cancer, node negative, ER positive, HER2 negative, in those cases oncotype dx test it is beneficial. Clear? Now what is the important thing that you need to remember is oncotype dx scoring test. It helps to determine the likelihood of benefit from chemotherapy, number one, and number second is the chances of breast cancer recurrence. So this is the utility of oncotype dx test, and it is how many genes? 21 genes are taken into account. So the correct answer is option C. A 50-year-old man is brought to the emergency department with severe epigastric discomfort and left-sided chest pain radiating to back that began after waking up. He has also vomited several times since the pain began. Clear? He underwent an esophagogastroduodenoscopy the previous day for evaluation of epigastric pain. He is pale, anxious, and diaphoretic. His temperature is 37.9 degrees centigrade. Pulse is tachycardia. Respiratory rate also on higher side. Blood pressure is 100 by 60 in his upper extremities and 108 by 68 in his lower extremities. Pulse oximetry on room air shows oxygen saturation at 98% and S4 is audible over the precordium in addition to crepitus over the chest. Abdominal examination shows tenderness to palpation in the epigastric area. A 12-lead ECG shows sinus tachycardia with non-specific STT changes. Which of the following is the most likely diagnosis? Now, looking onto the clinical scenario, the patient has epigastric pain, multiple episodes of vomiting, and clear the patient is toxic. This is a case of what? It is a case of esophageal perforation. Clear? Now, in esophageal perforation, you know there is a triad which is termed as Mackler's triad. There is chest pain, epigastric pain, then there is vomiting and subcutaneous emphysema. Now, let us have a look on the first esophageal perforation. Then we will come to the question. So, esophageal perforation, it can be iatrogenic trauma due to endoscopy. Clear? Then placement of a feeding tube, it can also cause. Then we have Boerhaave syndrome, which is spontaneous esophageal perforation due to forceful vomiting, that is called as Boerhaave syndrome. Then it can be due to swallowing of foreign bodies. So all these are causes of esophageal perforation. Now there can be anatomical factors also which can be implicated. These are the high risk factors. These are Zenker's diverticulum and esophageal stricture. Clear? Now, Boerhaave syndrome, it is a special type of esophageal perforation in which it is basically what? There is spontaneous esophageal perforation. It is post-emesis, that is after vomiting, and which is the most common site? It is left posterolateral, frequently asked in exam. Left posterolateral site, it is the most common site which can get perforated in case of spontaneous esophageal perforation or Boerhaave syndrome. Now, the clinical features are the patient has chest and mid-epigastric pain, pleuritic pain worsened by neck flexion and swallowing, then mediastinal crunch, that is called as Hamman sign. Clear? Also frequently asked in one of the NEET PG entrance exam. Hamman sign is what? It is mediastinal crunch, specifically seen in esophageal perforation. The rapid development of sepsis. Diagnosis is we go for chest X-ray. It shows mediastinal ear. As you can see, these arrow mark, they show what? They are showing mediastinal ear in the mediastinum. Clear? And it is due to the ear which has entered into the mediastinum due to perforation of the esophagus. After that, the esophagogram is done. Treatment is we start on antibiotics, and if the patient presents within 24 hours, of perforation, the primary closure can be done. And if patient presents after 24 hours of perforation, that means there is enormous amount of contamination, their patient is in sepsis, in shock. In that case, we will go for diversion, that is esophageal diversion is done, and later on we go for closure of the proximal and distal portion. So diversion is done. Diversion esophagostomy is done if the patient presents late. Clear? Now, what is macular striate? It consists of lower chest pain or epigastric pain, vomiting, as well as subcutaneous emphysema. So it is macular striate. Again, very, very important. So in this case, the patient is suffering from esophageal perforation. Clear? Now let us try to rule out other options. In pneumothorax, the patient will have breathlessness. There will be decreased saturation, but in this case, you see the saturation is normal. Again, in pneumothorax, the patient will not be febrile. There will not be tachycardia. There will not be episodes of vomiting. So you can rule out this. Again, acute pancreatitis, the characteristic typical character of pain in acute pancreatitis is pain starts in the epigastric region. It radiates to the back and it is aggravated by spine position and is relieved by sitting or stooping forward. No such history is given in this patient. You can rule out pancreatitis also. Again, aortic dissection, it is an acute aortic dissection. There is acute chest pain. It radiates to back in the interscapular area. Clear? And the patient is in shock, but no such history is given in such patient. So you can rule out this also. Again, aortic dissection will not be associated with vomiting. There will be epigastric discomfort, but there will be no vomiting in such patients. Clear? So you can rule out aortic dissection also. So the correct answer is C. A 30-year-old male came to emergency department with severe abdominal pain. On examination, pulse rate is tachycardia. BP is on the lower side with tenderness all over the abdomen. His chest X-ray was done and is shown below. The most appropriate management is. Now, if you see the X-ray, there is gas under bilateral dome of diaphragm. So there is gas under bilateral domes of diaphragm. So it can be a case of perforation peritonitis. There is perforation of a viscus of an organ. So in perforation peritonitis, what happens? The patient has peritonitis. The patient will have guarding, rigidity, tenderness all over the abdomen, and bolt-like rigidity is seen. Now the patient is toxic. There will be tachycardia. The patient will be in the state of shock. So what will be the first step? We have to resuscitate the patient. We have to give IV fluids to the patient, followed by emergency laparotomy. So the correct answer will be A. Now let us try to have a look on other options. Intravenous fluid and antibiotic alone, no, it will not suffice. IV potassium will not suffice. Immediate laparotomy is to be done, but it has to be associated with IV fluids also, because we have to treat shock also. So this is also wrong. So the best possible answer is option A.